Welcome to Public Health on Call, a podcast from the Johns Hopkins Bloomberg School of Public Health, where we bring evidence, experience, and perspective to make sense of today's leading health challenges. If you have questions or ideas for us, please send an email to publichealthquestion@jhu.edu. That's publichealthquestion@jhu.edu for future podcast episodes.
It's Lindsay Smith-Rogers. Today, malaria, a disease that still kills around 600,000 people every year, most of them children under age 5. Just in time for World Malaria Day, Dr. Jane Carlton, the director of the Johns Hopkins Malaria Research Institute, sits down with Stephanie Desmon to discuss the deadly mosquito-borne disease and where things are today with trying to prevent it. While the fight has faced setbacks as mosquitoes and parasites evolve resistance and global funding is drying up, Dr. Carlton talks about the many fronts researchers are fighting, including vaccines, mosquito control, and even gene editing to prevent malaria's ability to spread, which all offer some hope. Let's listen. Jane Carlton, thanks so much for joining me.
Thank you very much for having me.
You are the director of the Johns Hopkins Malaria Research Institute. Can you tell us a little bit about what that is?
Yes, absolutely. The Malaria Research Institute was founded in 2001. In fact, it's our 25th anniversary this year, and it's been continuously supported by Michael Bloomberg and Bloomberg Philanthropies. And we are a concentration of malaria researchers based at the Bloomberg School of Public Health, but also with field sites in several African countries. There are a total of 16 or so tenure-track faculty, but with a total staff of close to 100. And we undertake research on all aspects of malaria, from developing new anti-malarial drugs to novel methods for controlling mosquitoes, new vaccine candidates. And we undertake both basic research, but also all the way through to translational, as I mentioned. So we develop assays and new targets in Baltimore, and then we take them over to our field sites that we have developed in partnership with many African colleagues.
Terrific. Today, in advance of World Malaria Day, which is April 25th, I was wondering if you could offer me a snapshot of where we are with malaria in 2026.
Yes, well, Malaria Day, which is coming up on April 25th, is really a call to arms for global action, also investment and sustained commitment to fight this deadly disease that kills hundreds and thousands of children in Africa each year. So in 2024, there were an estimated 280 million cases and 600,000 deaths. And these are primarily in children under the age of 5 in African countries. Malaria is one of the big 3 global infectious diseases, and it's been recognized by the World Health Organization as one of the deadliest and the most burdensome throughout history as well as currently. Malaria is actually caused by a parasite that infects human blood. It's transmitted through the bite of an infected mosquito. There are several species of human malaria parasite and at least 40 different species of mosquito that can transmit those species of parasite. Malaria is a treatable disease if caught early enough, but there are key threats to the progress to eliminate disease, and that's a big issue.
I know that funding, notably in the United States, but in other countries, funding for malaria prevention has been reduced in recent years, and it feels like progress might be stalling. Can you tell us about where that is?
Yes, this is very unfortunate. Over the past year or so, there has been a decided decrease, not only for the funds which go towards malaria surveillance and control, but also malaria research as well, which is key to developing innovative new technologies to fight the disease. The US global health system is really moving away from a contractor-led program towards these sort of bilateral agreements. And so this is raising concerns that rapid transition could disrupt delivery of malaria supplies in the lower income countries. And so this is really quite worrisome.
And the major tools we have to prevent malaria are?
We actually have several and several new ones as well, which are being rolled out. So we have 2 now World Health Organization approved malaria vaccines. And they are now being rolled out in more than 20 countries in Africa. These are primarily for children under the age of 5 to be inoculated. So this is great news for the children in those countries. We also have drugs as well. The main issue being that the parasite has become resistant to many of the antimalarial drugs, in particular artemisinin, which is the frontline antimalarial drug in current use, and resistance to that is spread in several African countries. We also have methods to control the mosquito. So that can be through the use of bed nets, through the use of spraying insecticide inside and outside of dwellings. A big issue there, unfortunately, is that the mosquito has become resistant to the insecticide which is used on bed nets. So that is a challenge. And another issue that we have is that there's an invasive mosquito species, Anopheles stevensi, which thrives in urban settings and is more resilient to warmer temperatures. And that has started to invade certain countries in the Horn of Africa.
This seems like it's a crucial time, and yet funding is being cut.
Yes, indeed. In fact, malaria has reduced worldwide over the past 50 years. If you have a look at a map, the malaria map, it has shrunk. And in particular, many countries in South America and also parts of Asia are now classified by WHO as being malaria-free. And so we've made a lot of progress. The problem is really countries in Africa, which are low and middle income countries, which lack the resources to really try and move forward towards elimination. But I think, there is, the end is in sight. Perhaps maybe some of your listeners might wonder, well, we thought we had already eliminated malaria. Why is it still an issue? And it is because it's a holdout in many of these countries. And these countries can be in war-torn regions, for example, or due to the issues of changes in the environment, deforestation, things like that. It means that malaria has rebounded in many of those countries. And so if we keep at it, if we keep the global initiatives, both on the surveillance side of things, but then also funding research, then I really think we can push forward elimination in many of the remaining malarious countries.
Are you optimistic?
That's a difficult one. One day I'm optimistic, the next day I'm not so optimistic. What I'm very optimistic about is the malaria community that exists both in the United States at the Malaria Research Institute, but then also globally as well. Researchers who've been working for years to develop better methods to control malaria. And we really continue to work together to try and really get rid of this scourge in so many of the countries. So that I'm optimistic about.
I wanted to go back to the vaccine for a moment. You mentioned that it's being rolled out in 20 countries. My question is, are people getting access to this vaccine? Are there campaigns to help people understand why they should take this vaccine? Is that kind of infrastructure around the vaccines in place?
Yes, it is actually. There are these 2 vaccines, and many of the African governments have put money towards rolling out vaccinations so that we can get the vaccine into the arms of children. And that is very promising. The pot of money that comes for that is through Gavi, and that is separate from the malaria surveillance and control. And so far, that seems to be being maintained, which is really good news. And then in terms of the research, actually within the Malaria Institute as well, we are undertaking studies to see about the implementation of the vaccine and how it is taken up, perhaps to see if there are better methods that we can roll this out, but then also on a basic research angle to see what the vaccine does to individuals in terms of priming their immune system. And are there potentially better vaccines that could be produced more easily in the coming years?
Are these vaccines a turning point in malaria or more of an incremental step forward?
That's a very interesting question. I've got to say, developing a malaria vaccine was in the pipeline for 30, 40 years. And it took about 12 or 15 years for approval of the very first one and then production by GSK. And both of the vaccines target the same protein on the malaria parasite. So while they are pivotal, there's no two ways about it, they could do with some improvement. For example, they do require a cold chain. They require 4 shots a certain period of time apart. And the efficacy, as well as the vaccines, has perhaps been lower than we would have liked. And so they're being recommended in conjunction with other anti-malarial treatments too. So they are key. They are very important. Whether they're pivotal, I think time will tell.
If there are these issues with the current vaccine, which we're happy to have, are there efforts underway to improve them?
Yes, there are other targets, other proteins that are produced by the parasite, for example, are being worked up as possible vaccine targets. But then in addition, I should say, just focusing on the parasite, because the parasite is really a crafty killer. And, parasites evolve. Instead of putting all of our eggs in one basket, in the vaccine basket, it's developing these other methods, in particular methods for mosquito control. And those are very key because if you can actually target malaria on all fronts, both the parasite and the vector, then that can really increase the ability to move towards elimination.
I understand that, for a long time, there's been a lot of reliance on insecticide-treated bed nets and spraying inside the homes, but that this new mosquito you spoke about actually has a different personality, right? So it behaves differently, and it doesn't bite people only at night. It can bite them during the day. How are we working to manage that change?
Yes, that's right. So the change in behavior of certain species of mosquito has been a very interesting finding. Actually, that predated this invasive species. And the finding that the mosquito can adapt its behavior to bite at different times of the day has really been instrumental in the way that we then view mosquito studies going forward. So mosquito behavior, as well as insecticide resistance of the mosquito to the insecticides which are found on bed nets, both of those are very key issues to keep in mind.
Seems like there are so many tricky elements to solving this.
There are, but I think we're bringing some very new innovative technologies to the front to try and bear fruit. One of the areas as well that we're working on is genetically modified mosquitoes. This obviously is a sort of brave new world technology. There are a couple of different ways that you can try to influence mosquito populations. The first is through mosquito population suppression. So this is when you spread a particular gene in a population so that only the males that survive. And so eventually the population crashes because then they can't breed. And then there's a mosquito population replacement, which is actually an area that we're working on. And this is where there's a gene or a mutation in a gene that already exists in the mosquito. That means that the parasite can't develop in the mosquito. So you're not going to affect the mosquito population, but you're going to make the parasite sort of resistant to malaria infection. So those sorts of genetic engineering approaches are also very important, and we're working on several of those at the moment.
So what do you think will make the biggest difference in the next 10 years?
I think it's really going to be a combination of all of these factors. I think an understanding that malaria has not been eliminated is going to be important. In fact, we had within the United States 10 cases of locally acquired malaria just a couple of years ago. And that's because we have the mosquito populations in this country which can transmit malaria parasites. And there are about 2,000 cases of malaria from people going abroad, either on vacation or visiting family, and then coming back to the United States. And so they bring the parasites back, and then those can enter the mosquito population. And that's what we saw a couple of years ago. So it is very important that we, as a country, a wealthy country, ensure that research and funding continues against malaria, because it is the US citizens who are going abroad who are affected. It's also troops, army personnel, when they're deployed to conflict zones which are malarious. So it's in our best interest, really, to keep up the staunch that we have against malaria.
Jane Carlton, thank you so much for joining me.
Thank you very much.
Public Health on Call is a podcast from the Johns Hopkins Bloomberg School of Public Health, Produced by Joshua Sharfstein, Lindsay Smith-Rogers, Stephanie Desmon, and Rachel Walsh. Audio production by Michael Bonfils, Matthew Martin, and Philip Porter, with support from J.B. Arbogast, Spencer Greer, and Chip Hickey. Distribution and social media by Rachel Walsh, with support from Nick Moran and Brianna Iacovelli. Follow us on Instagram and Blue Sky at Public Health Pod for more public health takes and special content. If you have questions or ideas for us, please send an email to publichealthquestion@jhu.edu. That's publichealthquestion@jhu.edu for future podcast episodes. Thank you for listening.